As we begin on the histology section, let us start with the details of the epithelium. And epithelium is the tissue which is lining the surfaces, maybe on the exterior of the body or maybe on the interior of the body. For example, the lining of the body tubes. Now, the epithelium, which is simple epithelium or maybe multi-layered stratified epithelium, in simple epithelium will have only single cell layer, but in stratified you'll have multiple cell layer. And in the simple epithelium, we are having three types, that is simple squamous, simple cuboidal and simple columnar epithelium. Let us talk about the details in this diagram then. And as we understand, when we talk about the simple squamous, as I mentioned, simple means it is single cell layered. And what do we mean by squamous? Squamous means it is going to be flat. It is going to be a flat cell with flat nucleus. But then as you observe in this diagram, the nucleus may be flat. This is the blue color nucleus. Nucleus is basophilic, takes more of blue color. The hematoxylin cytoplasm is eosinophilic, takes more of the pink color. So the nucleus may be flat, but the nucleus may be globular also. But it will be a small nucleus and little of cytoplasm. The nucleus is going to bulge towards the exterior, towards the surface, as you can see. So as you draw this diagram, simple squamous epithelium is going to have a flat cell with a flat nucleus. On the other hand, when we are talking about simple cuboidal epithelium, simple means it is single cell layer. In cuboidal epithelium, you will see the height of the cell is equal to breadth of the cell. So as we draw it here, the height of the cell is equal to breadth of the cell, and there will be a central spherical nucleus, which can be seen in the diagram as well. The height of the cell is equal to breadth of the cell, and then there is a central spherical nucleus. This is the basement membrane on which we have a cuboidal cell. The height of the cell is equal to breadth of the cell, and there is a central spherical nucleus. Central means distance from the basement membrane and from the apical surface is almost equal. So that is the simple cuboidal epithelium. Whereas as we look at the simple columnar epithelium, simple again, it means single cell layer, it is not multi-layer. So what do you mean by columnar? Columnar means the height of the cell is greater than the breadth of the cell. As you can notice, this is the basement membrane on which we have multiple columnar cells, and the height of the cell is more than the breadth of the cell. As you notice the same here, the basement membrane on which multiple columnar cells, and the height of the cell is more than the breadth of the cell. Plus we observe there is oval basal nucleus. The nucleus is oval and it is more towards the base. Though it is not very close to the base, but comparatively, as you see the distance of the nucleus from the surface and the basement membrane, the nucleus is more towards the base. Here it appears as we explained, but there it is almost reaching the middle of the cell because of so many approximated cells close to each other. But still we say oval basal nucleus, and it is vertically aligned. The oval dimension is vertically aligned, as you can see. So this is simple columnar epithelium. But how we are going to identify them immediately in a histological slide? For doing so, you can understand one thing here. In case of simple squamous epithelium, the amount of cytoplasm which is above the nucleus, it is very scanty. So little cytoplasm which is above the nucleus, it is attenuated because the cell itself is so small, almost entirely occupied by the nucleus. So the cytoplasm above the nucleus is very scanty. Is this evident? Here also the cytoplasm above the nucleus will be very much attenuated. The same can be seen here. This is the cell, and you can find the cytoplasm above the nucleus is very scanty. But as you see now, it has increased in the cuboidal cells. So cytoplasm above the nucleus is a bit increased, which is evident here as well. And the same you can see in the schematic diagram as well. The cytoplasm is in ample quantity. So this is the cytoplasm, which is yet more increased in case of the columnar cells. The cytoplasm is now quite in abundance above the nucleus. So this is the cytoplasm we are talking about. You can see the epithelium can be identified by just by looking at the nuclei. If you find there is a lot of cytoplasm of the nucleus, it is going to be the columnar cells, and comparatively if it is less cytoplasm above the nucleus, you compare this height of cytoplasm with this height of cytoplasm. This is cuboidal and that is columnar. But as you come here, you find little very minimal cytoplasm of the nucleus. It is scanty. So just by looking at a flat cell with flat nucleus, or a cuboidal cell with central spherical nucleus, or a cell with increased height and with oval basal nucleus, you say it is columnar. Now a question comes, what are thyroid follicles lined by? Generally, thyroid follicles are lined by cuboidal epithelium. But if it is actively secreting thyroid follicle, then it will have more of endoplasmic reticulum, more of secretions, and the height of the cell will increase. So actively secreting thyroid follicles will have columnar epithelium, whereas normal thyroid follicles will have simple cuboidal epithelium. And it may happen that if there was less of secretion from the thyroid follicle, they might change into simple squamous epithelium, because less of secretion, less of endoplasmic reticulum, so less of height in the cells. And as we move on to the details of simple squamous epithelium, you can see simple means it is a single cell layer. Squamous means it is a flat cell with flat nucleus. These type of epithelia are seen at various places. One example is mesothelium. For example, mesothelium is simple squamous epithelium lining the pericardial cavity, the pleural cavity, and the peritoneal cavity. So as we talk about these cavities, the pericardial, pleural, or peritoneal cavity, they are lined by mesothelium, which is simple squamous epithelium. Then as we talk about the endothelium, which is the epithelium lining the heart or the blood vessels, or even the innermost layer of cornea, the corneal endothelium, is again simple squamous epithelium, flat cell with flat nucleus. And then the type 1 pneumocyte of the lung alveolus. So as we look at the lung alveolus, there will be a flat cell with flat nucleus. That is the type 1 pneumocyte. It is also simple squamous epithelium. And then as we look at the kidney tubules, say for example the loop of Henle, it is simple squamous epithelium. We need to remember various examples as the examiner keep asking about them in the form of MCQs. Here we have taken the peritoneal covering of the stomach, and as we see, they are the mesothelial cells, the peritoneal cells, having a large nucleus as compared to the amount of cytoplasm, and as such it will be simply a flat cell with flat nucleus. But the nucleus can sometimes be globular. As you see in this example, the nucleus is globular, and in fact it is protruding inside the lumen, and as is evident, the cytoplasm which is above the nucleus is very scanty. Very little of cytoplasm seen above the nucleus as you compare it with the cuboidal cells or the columnar cells. The simple cuboidal epithelium, as we look at the various sites, we will find that they are present in the thyroid follicle. As we have mentioned, normally the thyroid follicles are lined by simple cuboidal epithelium. Then, as we mentioned, the renal tubule, it could be the proximal convoluted tubule or distal convoluted tubule. They will have simple cuboidal epithelium. And then talking about the glands, especially the serous glands and even the ducts, they are lined by cuboidal epithelium. Now, in this diagram, we are looking at the kidney and the renal tubule. In the renal tubule also focusing upon the distal convoluted tubule. So this is the distal convoluted tubule in the kidney, and as we observe, the height of the cell is equal to breadth of the cell. There is a central spherical nucleus. The same can be mentioned here. The height of the cell is equal to breadth of the cell. There is a central spherical nucleus, and the amount of cytoplasm above the nucleus is quite significant if you compare it with the simple squamous epithelium, where it is scanty, attenuated. So just by looking at the nuclei, you can mention whether it is a simple squamous epithelium or cuboidal or columnar. Your eyes must be trained to quickly identify the type of cells. This is a low magnification, and we should know that is how the simple cuboidal epithelium will appear. In fact, by just looking at the nucleus, flat nucleus, simple squamous epithelium. If it is central spherical nucleus, cuboidal epithelium. If it is oval, vertically oriented, basal nucleus, it is columnar. But here, most of these cells are having central spherical nucleus. So this is a low magnification of cuboidal epithelium in the renal tubule. Then we move on to the examples of the simple columnar epithelium as well. And here we are looking at the simple columnar epithelium, a single cell layer columnar epithelium, and the sites as we talk about could be the gut tube, starting from the stomach and moving on to the intestine, may it be the small intestine or the large intestine, they are lined by simple columnar epithelium. Even the gallbladder is having simple columnar epithelium, but then it will have what is called as the microvilli, the apical projections to increase the surface area for absorption. The microvilli are also present in the small intestine. We should remember the function of columnar epithelium and even the cuboidal epithelium. Number one, the cuboidal epithelium or columnar epithelium, they are involved in secretions. And number two, they are involved in absorption. And to increase the absorption, they can have microvilli. Like in the small intestine, you have microvilli to absorb the nutrients, whereas in the gallbladder, the microvilli will serve as to absorb the excess of water in the bile to concentrate the bile. And these microvilli, which are finger-like apical projections, can be identified in the histological slide by looking at deeply eosinophilic surface modification. That is how the microvilli will appear in the histology slide. So your eyes must be trained to identify the microvilli. This appears like the striated border. The striated border where you have the height of microvilli very uniform as seen in the small intestine. Small intestine has striated border and the height of microvilli is uniform. Plus, as you can see, this is a tall columnar cell with vertically aligned oval basal nucleus. Now the nucleus may not be basal. As you see, a lot of cells are there. The nucleus may be pushed slightly higher. It doesn't appear to be basal. But one thing is, you have to look at the cytoplasm, the column of cytoplasm above the nucleus. It is evident that if you have that much of cytoplasm above the nucleus, it cannot be a simple squamous epithelium. It cannot be cuboidal epithelium. That much of abundant cytoplasm of the nucleus can go only in favor of columnar epithelium. So maybe the oval nucleus is not basal. It is appearing right in the middle of the cell, but it is then oval and vertically oriented and more of cytoplasm of the nucleus. As you can see in a low magnification, above the nuclei there is lot of cytoplasm, abundance of cytoplasm. Plus this is how the microvilli or the striated border will appear. So your eyes must be trained to find that deeply eosinophilic surface apical modification called as the microvilli. This is simple columnar epithelium with striated border, as can be observed in the small intestine. And as we are mentioning about the sites where we have the simple columnar epithelium, one other example is the uterine tube. But in uterine tube, it will be simple columnar epithelium, some of them having even the cilia to move the conceptors towards the uterine cavity. And as we talk about the renal tubule, especially we are focusing upon collecting duct, there can be simple columnar epithelium with scanty microvilli. Again, the microvilli are to increase the surface area for absorption. So these are the various places we can have the simple columnar epithelium with some surface modifications. Here we have talked about microvilli, and some places it could be even the cilia, like in uterine tube. In these diagrams, we see multiple levels of cells sitting on the top of each other. So they are multi-layered. They are not simple epithelium. And the very first example in this can be taken that of the stratified squamous epithelium. So here we see the stratified squamous epithelium. The name squamous comes because of the topmost cells. They have flat cell having flat nucleus, giving the name stratified squamous epithelium. Though if we look at the multiple layers towards the basement membrane, we may have columnar or cuboidal cells. So there will be basal columnar cells becoming cuboidal and eventually becoming squamous cells. But the topmost layer is used to name the epithelium, stratified squamous epithelium. Stratified means multiple layer of cells, multi-layered. And one example is the skin. As you see, the skin epithelium, which is called as the epidermis. This is the skin epithelium, the epidermis, and below that is the dermis, which is subepithelial connective tissue, forming some finger-like processes into the dermis. But here we focus upon stratified squamous epithelium. Basal cells can be columnar, in the middle we have cuboidal, and the topmost cells, you can see the flat cell with flat nucleus, simple squamous epithelium. And then some keratin is also observed because this is skin. In the skin, we have the keratin to keep the surface dry. But then in the next diagram, you will see there is no keratin. This is also stratified squamous epithelium, but is non-keratinized. So, stratified squamous epithelium, which is non-keratinized, where do you find such an epithelium? One good example is the esophagus. And another example is the vaginal epithelium. So, epithelium of the vagina vagina or the esophagus is stratified squamous epithelium but non-keratinized. Here, even the topmost cells, which should be flat cell with flat nucleus, but not necessarily the nucleus could be globular, so it will be a small globular nucleus, especially if you're talking about stratified squamous epithelium in the esophagus vagina. The topmost cells will have nucleus, but that is not observed in the skin or the keratinized epithelium. The topmost cells are dead cells and they do not show any nuclei. So the topmost cells without nuclei in keratinized stratified squamous epithelium, but the topmost cells in non-keratinized stratified squamous epithelium will definitely have nuclei. So flat cell with flat nucleus or globular nucleus which is small. The example is esophagus and the vagina as you locate this kind of epithelium. Now coming to the next one, as you see, this is the urothelium or the urinary epithelium, which is also called as the transitional epithelium. So where do you see the urothelium or transitional epithelium? It is the name telling, urinary epithelium. For example, in the ureter or the urinary bladder, the proximal urethra can have transitional epithelium, and it is appearing same as the stratified squamous, but there are some differences, though it is also appearing multiple layered, which could be the basal cells columnar becoming cuboidal. But then one major difference is the superficial cells which are towards the lumen, like lumen of ureter or lumen of urinary bladder. They are large dome-shaped cells, also called as umbrella shape. This appears like an umbrella, and under the umbrella you can see there are a lot of cells being protected from the hypothetical rain. The point is the topmost cells towards the lumen, they are very large cells as compared with the small cell in stratified squamous epithelium. Here the topmost cells are flat or small, but here in transitional epithelium the topmost cells are the largest of all the cells, which is evident here again. Maybe it is multiple layered, appearing like the stratified squamous epithelium with the basal cells columnar or cuboidal, but the topmost cells, they're not flat cells or small cells. They are large cells with large nucleus, and sometimes there can be even two nuclei in a single cell. So dome-shaped large cells which are projecting into the lumen of the urinary bladder or ureter, and umbrella-shaped cells under cover of which you can have multiple 4-5 cells, and these cells will have reserve cell membrane. They have the stretchability. If there is a lot of urine in the urinary bladder, then the epithelium will stretch. And if the urinary bladder is empty, then they'll be relaxing. This 8 to 10 cell layer which you find here, like in this epithelium, transitional epithelium can appear 8 to 10 cell thick, but then it can stretch and become only 3 to 4 cell thick if there is a need of stretchability, like more of urine in the urinary bladder. And the reserve cell membrane, which these topmost cells, which are large globular cells, as compared with the very small flat cell with flat nucleus or even the small globular nucleus. You compare the topmost cells of stratified squamous with the transitional, they are definitely very large. And because of that reserve cell membrane, they can give us this eosinophilic plaque-like appearance. Because of the reserve cell membrane, the plaque-like appearance comes towards the luminal side in transitional epithelium. Now coming to the third variety here, we see this is the pseudo-stratified ciliated columnar epithelium. Now why would we say it is pseudo-stratified? As you will notice, the epithelium gives the appearance of being multi-layered because of the different level of nuclei. Nucleus at a higher level, at a middle level, at a lower level, giving us the appearance of multi-layered epithelium, which it is not, because each cell is touching the basement membrane. And since each cell is touching the basement membrane, it cannot qualify as stratified. So what it is? It is called pseudo-stratified. It is not stratified, but appearing like stratified. So pseudo-stratified. And then you can see there are some apical modification also, the cilia. As you look for the cilia, they are fine thread-like modifications at the apical lesion, more clearly evident here. So these are the cilia, which are fine thread-like processes, could be used to move the fluid in the lumen. For example, respiratory epithelium is pseudo-stratified ciliated columnar epithelium to move the mucus. Whatever air we are breathing, it may bring some dust and the bacteria, and you want to move this dust and bacteria outside to cough it out. So cilia will be helping in that. And once again, you can see the nuclei at a higher level, at a middle level, at a lower level, giving the appearance of being multi-layered epithelium, which it is not, because each cell is touching the basement membrane. It cannot qualify as stratified. So it is pseudo-stratified and then ciliated. Why would you say it is columnar epithelium? The nuclei, they are not appearing oval or basal, not at all places. So oval basal nucleus can be seen in some of the cells, but not everywhere. Again, the point is, if you could see more of cytoplasm, abundance of cytoplasm above the nucleus, then it is going in favor of columnar epithelium. As we understand, it cannot be squamous epithelium, where it will be scanty cytoplasm. It cannot be cuboidal, which will be moderate cytoplasm. This is more of cytoplasm, a large column of cytoplasm of the nucleus, so goes in favor of columnar cells. And as we have mentioned, the pseudo-stratified ciliated columnar epithelium can be seen in the respiratory tract. One example which you can remember is the epiglottis. Laryngeal surface of epiglottis comes as a question. It has respiratory epithelium. Let us talk more about these kind of epithelia now by taking one sagittal section of the head-neck region. And before we start talking about the various epithelia in the sagittal section of the head and neck region, we should remember one rule. The rule says any external opening in our body is lined by stratified squamous epithelium. So for example, the oral cavity, the opening, or the nasal opening, or the external ear opening, or the first layer of cornea, the eye opening. Any external opening is lined by stratified squamous epithelium. And here in this diagram, we'll be talking about two tubes developing together, the gut tube, and from the gut tube comes the respiratory tube. So as we look at the external opening, the gut tube, that is the oral opening, as per the rule, it will be lined by stratified squamous epithelium, and it is actually keratinized. So there will be keratin at the beginning. May it be the lips or the dorsum of the tongue to a certain level, and even the hard palate, all is lined by the keratinized stratified squamous epithelium. The same can be seen even in the nasal vestibule. So as we look at the opening of the nose, the nasal vestibule, we'll find it is also lined by stratified squamous epithelium, which is keratinized. As per the rule, any external opening should have this epithelium. But as we go deeper, let us follow the oral cavity first. We see that now the epithelium changes. So in the deeper part of the oral cavity, like the tongue or the soft palate, the epithelium is non-keratinized. It has become non-keratinized stratified squamous epithelium. So we lose keratin in the deeper portion. And the same is seen on the lingual tonsil or even the palatine tonsil. So may it be the tonsil on the palate, the palatine tonsil, or maybe the tongue, the lingual tonsil. Tonsil are being lined by non-keratinized stratified squamous epithelium. And the same epithelium will be seen on the oral part of the epiglottis hair or the lingual part of epiglottis. Epiglottis is the lid over the larynx, and it will have two surfaces, one towards the tongue, the oral surface, and one towards the larynx, the laryngeal surface. But here we are talking about the oral surface of epiglottis, and it will be having the same epithelium, which is non-keratinized stratified squamous epithelium. And this epithelium is also seen on the true vocal cords. So here we have the larynx, the true vocal cords, and even the true vocal cords are lined by the non-keratinized stratified squamous epithelium. This kind of epithelium is helping us to protect against the aberration. And if you are talking about the vocal cord, the true vocal cord, it is exposed to fast-moving air like coughing, sneezing. So to protect from aberration of the fast-moving air, even the vocal cord is being lined by the same epithelium, which is stratified squamous epithelium. But then what about the laryngeal surface of the epiglottis or the false vocal cords? Since this is the respiratory tube, it will have the respiratory epithelium. And as you talk about the respiratory epithelium, we can start with the nasal cavity itself. The nasal cavity and the paranasal sinuses, they'll all be having the respiratory epithelium. Respiratory epithelium, as we understand, will be the pseudo-stratified ciliated columnar epithelium with goblet cells. So pseudo-stratified and ciliated columnar epithelium with goblet cell will be seen in the nasal cavity, in having the paranasal sinuses. Even in the nasopharynx, where we have the opening of eustachian tube. And there we have the adenoids also. Even adenoids will be lined by respiratory epithelium, which means pseudostratified ciliated columnar epithelium with goblet cells. And the same epithelium will find even in the laryngeal surface of epiglottis. So this is the epiglottis, the lid over the larynx, and it has one laryngeal surface. So basically the epiglottis is having dual epithelium. On one surface, which is towards the tongue, the lingual surface, it is different. That was the non-keratinized stratified squamous epithelium, as we have mentioned earlier. But towards the larynx, the laryngeal surface will have respiratory epithelium, pseudostratified ciliated columnar epithelium with goblet cell. And the same can be seen in the larynx, the trachea, bronchus, bronchioles in the initial part. So if we are talking about the vestibular fold or the false vocal cord, that is going to have the respiratory epithelium. And to explain it further, we have magnified the dual surface of the epiglottis and the dual lining of larynx histologically seen there. So as we talk about the epiglottis, first of all we should know the oral or the lingual surface of epiglottis is to be lined by the stratified squamous epithelium. So this is the stratified squamous epithelium, and as we have mentioned, it is non-keratinized. Now moving on to the laryngeal surface, as we can see, the laryngeal surface is lined by the respiratory epithelium. So if we look at the histological picture, the tip of the epiglottis and the laryngeal surface will be lined by the respiratory epithelium, and that respiratory epithelium, as we understand, is the pseudo-stratified ciliated columnar epithelium with the goblet cells. And we should know that the core of the epiglottis as such is made up of elastic cartilage. So there is elastic cartilage core in the epiglottis, which will be having a lot of elastic fibers, some collagen fibers, and a lot of chondrocytes. But if we are talking about the epithelium, there is dual epithelium. The oral surface is the non-keratinized stratified squamous epithelium, and the lingual surface is the respiratory epithelium, which was evident here. The same can be told about the larynx as well. Most of the larynx is lined by respiratory epithelium, which can be shown in the magnified picture here, including the false vocal cord, the vestibular fold. So this is the false vocal cord, the vestibular fold, lined by the respiratory epithelium, which we have mentioned is pseudo-stratified ciliated columnar epithelium with goblet cells. So here is the epithelium which is lining the false vocal cord, even most of the laryngeal cavity. But as we come to the true vocal cords, now you see there is a change. The true vocal cords are actually lined by non-keratinized stratified squamous epithelium, which is protecting us against the abrasions of fast-moving air, but only this much of the laryngeal surface. So as we see, this is the true vocal cord. Only that part is lined by non-keratinized stratified squamous epithelium. Otherwise, rest of the larynx or respiratory tube is having respiratory epithelium. So beyond this true vocal cord, again you'll have the respiratory epithelium. In the larynx or trachea, bronchus, bronchioles, it will continue downwards. Now, sometime it may happen, especially in the chronic smokers, this squamous epithelium may encroach upon the laryngeal surface, and as it does so, it is called as squamous metaplasia, which can change into dysplasia and cancer, CA larynx. So when the respiratory epithelium is changing itself into squamous metaplasia, dysplasia, it becomes dangerous, CA larynx. And one more thing can be noted here. Though the epiglottis, we have mentioned, it is having elastic cartilage, but most of the respiratory tube is having hyaline cartilage. As you see here, this cartilage which is being observed in the larynx is having chondrocytes in a glass-like matrix, hyalos. So hence called as hyaline cartilage. So matrix is appearing glass-like or hyalos, hyaline cartilage with the chondrocytes. This section we have taken from here, most of the larynx cartilage, including the thyroid cartilage or the cricoid cartilage, they are all made up of hyaline cartilage, and a section of the thyroid cartilage can be seen. So laryngeal cartilages are mostly hyaline, but with few exceptions. Like if you talk about the lid over the larynx, that lid over the larynx epiglottis was made up of the elastic cartilage, as we have mentioned here, having a lot of elastic fibers and the chondrocytes. And then we continue looking at further details of the respiratory tube and the gut tube, but along with that, we'll also focus upon the renal tube and genoidal tube in this diagram. We already have mentioned that the esophagus is lined by the stratified squamous epithelium, which is non-keratinized epithelium. If you remember when we were talking about the comparison of the keratinized stratified squamous epithelium, which is seen in the skin, with the non-keratinized stratified squamous epithelium, we named the esophagus. Actually, in the oral cavity and the oropharynx and then the esophagus, they are all lined by stratified squamous epithelium. In the beginning of the oral cavity, like the hard palate or the dorsum of the tongue, may have keratinized stratified squamous epithelium, but as you go deeper to the soft palate or the deeper part of the tongue or the oropharynx or the esophagus, keratin is lost. So it is now stratified squamous non-keratinized epithelium. But as we reach towards the lower part of the gut tube, that is the stomach and the small intestine, they will have simple columnar epithelium. So talking about the stomach or the small intestine will have the columnar epithelium, and the epithelium at these places will be forming the glands also. So gastric glands in the stomach and intestinal gland in the intestine. Maybe the small intestine or the large intestine, they'll have this simple columnar epithelium. But there's a difference between small intestine and the large intestine. Small intestine will be involved in a lot of absorption, so it'll have three modifications. Number one, it'll have these plicae circularis, the mucosal folds, to increase the surface area of absorption. Plus, it'll have the finger-like modifications, the villi, and microscopically, the epithelium will have microvilli. So, plicae circularis and the villi and microvilli, these three modifications are seen in the small intestine to increase the area of absorption. But these three modifications will be absent from the large intestine, and it is also absent from the stomach. Stomach does not have any plicae circularis or villi, microvilli. Now, as we talk about the respiratory tube, it starts from the nose, and then even in the larynx or trachea bronchus will have the hyaline cartilage. That is giving us the rigidity to maintain the patency of the respiratory tube. You cannot have the respiratory tube collapsing. That will stop the airflow. So to give the patency to the respiratory tube, starting from the nasal cartilage and the larynx, trachea bronchus, they'll have the hyaline cartilage. With few exceptions, at some places we can have elastic cartilage. For example, we have mentioned epiglottis is an exception. It will not have the hyaline cartilage. It was having elastic cartilage. Now in the respiratory tube, starting from the nasal cavity, we have respiratory epithelium, and that respiratory epithelium is the pseudo-stratified ciliated columnar epithelium with goblet cells. Goblet cell will give the mucus, which will trap the dust particle, bacteria, etc., which can be moved by cilia to cuff it out. Later, when the lumen of the respiratory tube becomes smaller, for example, at the level of bronchioles, the lumen is very small. There you do not have the goblet cell, so no mucus. So cilia will decrease in number, and even the hyaline cartilage will be lost. So this goblet cell, the hyaline cartilage, they are stopping at the level of bronchus. They are not present at the level of bronchioles. And even the cilia keep reducing in number as we enter the bronchiole level. What replaces the hyaline cartilage is the smooth muscles. So normally we'll have smooth muscles in the respiratory tube, but it'll be more in the bronchiole level, which will be helping us in bronchoconstriction and bronchodilation. So this is about the respiratory tube. When we come to the renal tube, we have seen, may it be the ureter or urinary bladder or the proximal urethra, will have the transitional epithelium. So transitional epithelium is multi-layered and could be 8 to 10 layers, which can become 3 to 4 layers if there is stretching of the epithelium. They have reserved cell membrane to stretch, and even the top cells are very large, globular, dome-shaped cells protruding into the lumen of the renal tube. Now, initial part of the urethra, may it be the male or female, they'll have transitional epithelium. But as you talk about the openings, like the male urethra, the tip of the male urethra or female urethra opening, what will be lined by? We already have mentioned about a rule. Any external opening in our body is to be lined by stratified squamous epithelium, which is preventing against the aberrations. So terminal urethra will be lined by stratified squamous epithelium. Even the vagina will be lined by stratified squamous epithelium. The anal canal. In the perineum, we have 3 openings. If it is a female, may it be the urethra, vagina, vagina or anal canal. The external openings, they are all lined by stratified squamous epithelium, but they are non-keratinized. These are body tubes and usually they are wet. They cannot have keratin, of course with few exceptions, but mostly they are non-keratinized. But when you talk about the skin epithelium, it is keratinized. Keratin will keep the surface dry. So when we talk about the skin epithelium, it is stratified squamous keratinized epithelium, and the epithelium will be forming some glands like the sweat glands or sebaceous glands. So what is the difference between this stratified squamous epithelium or the stratified squamous epithelium of the esophagus or the vagina? Actually, there we don't have keratin. It is non-keratinized. Wet surfaces should not have keratin. So esophagus is non-keratinized, vagina is non-keratinized, stratified squamous epithelium. Now these are body tubes, and body tubes will be usually having 4 layers. Towards the lumen there will be mucosa, and under that there will be submucosa. Exterior to that there will be muscular externa, and still outside there will be adventitia, the connective tissue adventitia. So as you can see, esophagus, most of it will be having connective tissue adventitia. The 4 layers can be seen. The epithelium will be on the mucosa. Under that we'll have the submucosa, which is some connective tissue with neurovascular bundle. Then we have muscular externa, and then we have the connective tissue adventitia. But the lower part of the esophagus will be covered by peritoneum, and then the connective tissue adventitia will be replaced by the mesothelial serosa or the peritoneal epithelium, simple squamous epithelium. As we know, the serosa, the peritoneal epithelium, is mesothelium, simple squamous epithelium. We have mentioned that mesothelium is present in the abdomen, the peritoneum, in the heart, the pericardium, and the lungs, the pleura. These mesothelial layers have simple squamous epithelium. So is seen in the serosa of the stomach or the serosa of the small intestine. This is again the peritoneum, which is mesothelium, simple squamous epithelium. So again we can see that this is gut tube. It will have the 4 layers. Innermost is the mucosa lined by simple columnar epithelium. Then we have the submucosa, muscular externa, and serosa. The same can be seen not only stomach but also the small intestine. And the arrangement of the muscular externa, the smooth muscle, is such that there will be one inner circular layer and outer longitudinal layer. That is to have the peristaltic movement, to push the food matter further by peristalsis. The same can be seen in the renal and genital tube also. Mucosa, submucosa, then there is this muscular externa and the connective tissue adventitia. But there is reverse arrangement of smooth muscles here. Inner layer is longitudinal and outer layer is circular. May it be the renal tube or may it be the genital tube. It is reverse of that of the gut tube. But be careful, at such places we can have additional layer of smooth muscles to the exterior. And as we have mentioned earlier, the epithelium can form the glands. The glands can be classified into 3 types according to the mode of secretion they are having. And we are going to look at the 3 types, their structure and also the location. The very first we are looking at is called as the merocrine, or the other name is the acrine type of gland. Whereas the second one is the apocrine variety of glands according to the type of secretion, the mode of secretion they are having. And the third one is the holocrine type of secretion. So looking at the very first, which is merocrine variety or the acrine variety, here we see this is the nucleus, and around the nucleus will have the endoplasmic reticulum making the secretions, which will be then pushed towards the Golgi bodies, which are supranuclear in location and midway between the nucleus and the apical surface. Then they'll be sending the secretion after packaging them, and the secretions are being secreted into the lumen without loss of cell membrane. If you do not lose cell membrane in the process, then you call it as merocrine or acrine variety. One example is the salivary glands. For example, the parotid salivary gland, as mentioned here, is merocrine or acrine variety of secretion. Whereas if we talk about the apocrine variety of glands, the apical portion of the cell membrane is being lost and covering the secretion. So apical loss of cell membrane, apocrine. That is how the name comes. And one example is the mammary gland. There are other examples also which belong to the apocrine variety of glands, like the wax gland, ceruminous glands in the external ear canal is apocrine sweat gland. It is a modified sweat gland of apocrine variety. Most of the sweat glands are actually acrine variety, with few exceptions where we can have apocrine sweat glands, and one of the apocrine sweat gland is ceruminous gland. Another example of modified apocrine variety of sweat gland is the mammary gland. It is also modified sweat gland of apocrine variety. Apocrine sweat glands are having very limited distribution and can be seen in the axilla, in the periareolar region, the mammary gland, and in the perineal region, around the openings of the urethra, vagina, anus. So there you'll have apocrine glands, but be careful. The places which we have named, the axilla, periareola, or the perineal region, not only they'll have apocrine sweat glands, but they also have acrine sweat glands. Most of the body will have acrine sweat glands, but in addition, we may have apocrine sweat glands also, as we mentioned these regions. Now, that was about the apocrine secretions. What about the holocrine secretion? In holocrine, whole of the cell is destroyed. The cell membrane is ruptured, cell organelles are disintegrated, and they become the secretion. So as you see, holocrine means whole of the cell is broken, nucleus is broken, Golgi body is broken, endoplasmic reticulum broken, the cell membrane is compromised, and everything become the secretion. For example, the sebaceous gland in the skin. So as we look at one histological specimen of the skin, say this is the skin with the hair follicle, related with the hair follicle we have the sebaceous gland, and sebaceous gland will be giving a secretion called sebum. Near the hair follicle there's a duct and which will be lubricating the hair follicle. Then this sebaceous gland is holocrine variety of gland. As you see here, this is the sebaceous gland which is having a lot of cells pouring their secretion along with the hair follicle. This is the skin epithelium which is stratified squamous keratinized epithelium. As we have mentioned, stratified squamous keratinized epithelium is the one which lines the skin, and even along with hair follicle this epithelium comes down. Along with the hair follicle we have this gland. We have magnified the sebaceous gland. As you can see, this is the region of the sebaceous gland. The peripheral cells are having intact cell membrane, intact cell organelles. But as we move towards the duct, we find the cell membrane is being compromised. The organelles are compromised. The cell is ruptured, and all that becomes the secretion, that is the sebum. So whole of the cell is being destroyed, becoming the secretion. This is called holocrine mode of secretion. Sebaceous gland is holocrine type of gland. Now in this diagram of the skin, you can also see some sweat gland in the dermis. So let us magnify these sweat glands and talk about their secretion. As we have mentioned, most of these sweat glands, they will be of acrine variety, but some of them could be apocrine sweat glands. Let us first focus upon the more common type. Magnify this region, talk about the acrine variety, which is also called merocrine variety. So here these are the cuboidal cells which are giving us the secretion. The secretion coming from the acrine glands, that is the sweat, is thin and watery. As you see in the palm or the sole, they are purely acrine variety of sweat glands. And as you still magnify them, there is no loss of cell membrane. You see the lumen is having smooth contour. In the lumen you'll have the thin watery secretion. This is the cuboidal cells which are making the sweat gland, which is acrine variety. Central spherical nucleus, height equal to breadth, simple cuboidal cells making the acrine type of sweat glands. But you see the lumen is having smooth contour. There is no loss of cell membrane, and this is what we are calling as the acrine or merocrine variety of sweat gland. Now compare them with the apocrine variety. The apical portion of the cell membrane is lost to cover the secretion, and the contour of the lumen cannot be smooth as we are losing the cell membrane and which is covering the secretion. Let us magnify it further and you see there is loss of cell membrane covering the secretion, and as the cell membrane covered the secretion, it will be forming what is called as the bleb. So there is bleb formation. These are the blebs, and the lumen cannot have smooth contour as we have mentioned. Plus apocrine variety of sweat glands, they'll have larger lumen as compared with the lumen of the acrine variety. There the lumen is smaller comparatively. And acrine variety of sweat glands are present in the superficial region of the dermis. But if you talk about the apocrine variety of sweat glands, then they'll be present at a still deeper level. So apocrine are at deeper level, acrine are at superficial level in the dermis of the skin. These are some of the differences between the three type of glands. Then there is another classification of the glands based upon the type of secretions they are giving, whether it is serous secretion or the mucoid secretion or seromucous kind of secretion. Here we are taking example of the various type of secretion in the salivary gland. And when we focus upon the parotid salivary gland, the largest of all the salivary gland, we find it is majorly serous type of gland. The secretions are serous, thin, watery secretion. And if we are looking at the sublingual salivary gland, which is under the tongue, hence the name sublingual salivary gland, that is more of mucoid secretion. So there will be mucus acinus seen in the sublingual salivary gland, and the secretions are thick and viscous. As compared with the thin watery, this is thick and viscous secretions. That'll be mucoid type of secretion. And the third type, when we look at the submandibular salivary gland, which is under the mandible, it is a mixed type of salivary gland, seromucous. So under the mandible, we have submandibular salivary gland, and this is seromucous. It will partly have the serous acini and partly the mucinous acini, seromucinous type of gland. So how do you identify the serous cells from the mucinous cells? As is evident, if we are talking about the parotid salivary gland, which is chiefly serous variety, the serous acini, the cells are darkly staining. They take a lot of eosin, and we have magnified one of the serous acinus here. So darkly stained cells, and this is the lumen of the serous acinus, where we are mentioning will have thin watery secretion of the parotid salivary secretion, but they are darkly stained as compared with the mucinous type, which are lightly stained because the type of secretion they are having, they have empty look. So lightly staining, having empty look, and because of that light stain, they can be easily identified from the serous variety. So this is going to be the lumen. And as we have mentioned, in the lumen of the mucinous acinus lined by the mucus cells, the secretion will be thick and viscous. As we have mentioned, the sublingual salivary gland is chiefly having mucoid secretion. But then, as we talk about submandibular salivary gland, it is seromucous. And here, you can identify the two types found simultaneously in the slides. As we see in this slide, we are having not only the serous acini, which are darkly stained, but also the mucinous acini, which are lightly stained cells. And one special feature here, which is called as the serous demilune. A cap of the serous gland is sitting on the mucinous acinus. So this is the serous acinus, which is making a cap of serous acinus sitting on the mucinous acinus. And it is mentioned that the serous cells in this arrangement, having the arrangement of serous demilune, we call it as serous demilune. The serous cells are giving us some lysozymes, which are antibacterial and give some defensive activity. So this is serous demilune, and of course it will be seen in the glands which are mixed seromucinous type of gland. So a question comes, serous demilunes are seen in which type of gland? And you can say submandibular salivary gland will have this kind of arrangement. And you can notice one other thing here. The mucinous glands, there is so much of mucus in the cells that the nuclei are being pushed to the base. So as we draw the mucinous acinus, this is the lumen. The cells are appearing columnar, and the nuclei, if we look at the nuclei, they are being pushed towards the base. So columnar cells with basally placed nuclei due to lot of secretions, which are empty looking, lightly stained secretions, the mucoid secretions. As we can see here, the same detail. This is the mucinous acinus, and the nuclei are towards the base, flat basal nuclei. You can also show the lumen, which is here, and these cells are appearing columnar cells. So columnar cells with basally placed nuclei which are appearing flat. What about this structure which is on the top of that. What is this? This is what we are calling as serous demilune. And here the cells are serous cells. They have central spherical nucleus. So they are cuboidal cells. As you see, central spherical nucleus, the cuboidal cells in the serous demilune. We can also draw the same in our diagram here. On the mucinous acinus, we are having a cap of serous demilune, and the serous cells are having central spherical nucleus. That is the feature of cuboidal cells. And this serous demilune was giving us the lysozymes, the antibacterial enzymes for defense purpose. Now we need to discuss some more detail of this serous acinus in the next coming diagram. And as we were discussing, this is the serous acinus we were talking about, having the central spherical nucleus typical of cuboidal epithelium. This is one of the cell. This is towards the apex or the luminal side, and that is towards the base, the basement membrane side. So these are cuboidal or pyramid shaped cells, numerous of them making the serous acinus. This is the lumen where they'll be pouring the thin watery secretion as we were talking about. And this is not only true for the salivary gland, it is also for other glands like the pancreas, pancreatic acini. They're all giving merocrine type of secretion without loss of any cell membrane, may it be the salivary gland or the pancreas gland, the exocrine portion. And these serous acini, they have polarity in the cytoplasm. So cytoplasm is having some polarity. The base is blue and the apex is pink. So why the base is blue and apex is pink? Pink because it is taking more of eosin, eosinophilic apex. Then what about the base? The basophilic stain, that is hematoxylin. So base takes more of blue color or hematoxylin. But why the base is basophilic and why the apex is eosinophilic? As you will notice, in the serous acinus, the cells are having more of endoplasmic reticulum around the nucleus and more towards the base, actually taking more of hematoxylin. Since the endoplasmic reticulum, the ribosomes involved in protein synthesis, they take more of basophilic stain or hematoxylin. But as it comes to the apex towards the lumen, it will have zymogen granules, and these zymogen granules, which are basically the secretions like pancreatic enzymes, if it is a pancreatic acinus, or the salivary secretions in the salivary gland. So these zymogen granules, which are towards the apex, they'll be taking more of eosin. That is why there is a polarity in the cytoplasm. The base is more basophilic or blue color, whereas the apex is having these zymogen granules and which are taking more of eosin. So apex is pinkish or eosinophilic. And the same can be described in the electron microscopic picture also. We have to understand that around the nucleus and more towards the base, we were having the rough endoplasmic reticulum. So this is the rough endoplasmic reticulum, which is a cell organelle which is membrane bound, tubules which are having a lot of ribosomes involved in protein synthesis. And they are now packing the protein, making some vesicles, which will be then rupturing from the endoplasmic reticulum and moving on towards the Golgi complex. In the Golgi complex, which is again membrane bound cell organelle, doing the repackaging of the secretions and then making some lysosome like structures which will be coming near the plasma membrane, and then there will be release of the secretory vesicles by exocytosis towards the lumen. The same can be shown in this diagram also. This is the nucleus, and in the nucleus we can also see the nucleolus. So this is the nuclear membrane and this is the nucleus, this is the nucleolus, and surrounding the nucleus more towards the basal side, as we have mentioned, will be the endoplasmic reticulum with the ribosomes, hence rough endoplasmic reticulum making proteins or other secretions, and they are around the nucleus also. So as we mentioned, these are the rough endoplasmic reticulum. They are membrane bound tubules studded with the ribosomes and making some secretions. Those secretions are then sent towards the Golgi apparatus, which is supranuclear in location. So this question can come. Endoplasmic reticulum is towards the base. So base is bluish, whereas the Golgi bodies is supranuclear towards the lumen. Actually midway between the apical cell membrane and the nucleus, somewhere in the middle, we have the Golgi apparatus repackaging the contents and making some membrane bound vesicles, secretory granules as you see. They'll come and then attach to the membrane membrane and then come out into the lumen by the process of exocytosis. And there is no loss of cell membrane. This is acrine or merocrine type of secretion. Actually, in the exam, the markers can be on the secretory granules, the Golgi body, endoplasmic reticulum, or even the mitochondria. As you can see, these are the mitochondria, the powerhouse of the cell. And all these membrane-bound structures, as you notice, these are rough endoplasmic reticulum, perinuclear in location, studded with ribosomes, rough endoplasmic reticulum, making secretions, the zymogen secretions, and those zymogen granules, they are moving out towards the lumen. And because of these zymogen granules, we have the polarity. They take more of eosin. So the apex is more eosinophilic, whereas rough endoplasmic reticulum, which is towards the base, takes more of blue color. So base is more basophilic. Histology of the skin. As we understand, the skin will have two layers, the epithelium, the epidermis, and the subepithelial connective tissue, which is called as the dermis. So epidermis and dermis. The upper portion where you have the epithelium is the epidermis, and below that the subepithelial connective tissue is the dermis. We will talk about the dermis later on in detail, but presently our focus will remain on the epidermis. Usually if we are talking about the thick skin like that of the palm and sole, we'll have 5 layers to discuss. So what are the 5 layers of the skin epithelium, which as we know is stratified squamous epithelium and is keratinized to keep the surface dry. So the very first layer towards the outer surface is going to be the stratum corneum. This is the stratum corneum, and that is where we will have a lot of keratin fibers which are being desquamated, removed, shedding off. So that stratum corneum can be seen here also in a schematic diagram. This is the stratum corneum. These are basically the dead cells, the dead keratinocytes, and they are being removed from the surface. As we understand, the skin is exposed to a lot of abrasion and superficial layers keep getting desquamated. So that was layer number 1, the stratum corneum. Under that, if it is thick skin, we'll have the layer number 2, that is stratum lucidum. So this is the deeply eosinophilic layer, and that is the stratum lucidum. As such, the stratum lucidum will be found only in the thick skin like that of palm and sole. Otherwise, it will be missing. Like you will have the layer number 2, stratum lucidum, in the anterior of the hand, the palm, but it will be missing from the dorsum of the hand because this is thin skin. It will not have the stratum lucidum. And again, this stratum lucidum, the layer number 2, along with the stratum corneum, the layer number 1, both of them, they have dead cells, the dead keratinocytes which are being removed from the superficial layers. And then comes the layer number 3, which is stratum granulosum. There will be some keratohyalin granules here. So talking about the layer number 3, which is having keratohyalin granules, this is the stratum granulosum. And these granules, which are called as the keratohyalin granules, they are the one which will be forming the keratin fibers and sending it to the superficial layers. This third layer can be seen here as well. This is the stratum granulosum, and as you can see, the keratinocytes are having a lot of granules here, the keratohyalin granules, and because of these granules, there is formation of keratin in the superficial layers. So this was layer number 3. Then comes the layer number 4, the stratum spinosum or the prickle cell layer. Now, why it is called as stratum spinosum or the prickle cell layer? We can mention the name of layer is because of the type of cells which it is having. These cells, they are having some spiny appearance like this. And why these cells are having the spiny appearance like that? Because in histology slide preparation, these cells have detached from each other. They were bound to each other with the help of some desmosomes, and those desmosomal attachments have been removed. So they appear spiny in histology slide preparation. This is the 4th layer, and the spiny appearance is more evident here. The cells, as we see, they are having this spiny appearance. And why they are having this spiny appearance? They were having some desmosomal attachments, spot welding to hold on to other cells. And during the histology slide preparation, as the desmosomal attachments are lost, they appear spiny or prickle. So spiny layer or spinosum the prickle layer. These are the keratinocytes in the fourth layer. And in some dermatological conditions like pemphigus vulgaris, even in the living state, the desmosomes are being compromised. There are autoantibodies against the cadherins, which are cell adhesion molecules for the desmosomes. So in pemphigus vulgaris, there will be some skin blisters, intraepithelial lesions. This layer number 4, the cells are separating from each other, producing some blisters. That is pemphigus vulgaris. We can talk about that later as well when we talk about cell junctions. But at present, let us talk about the 5th layer as well, the stratum basale or stratum germinativum. It is single cell layer and is sitting on the basement membrane, having different type of cells. So this layer, which is a single cell layer, can be shown here also. The very basal layer is the one which is called as the stratum basale. So layer number 5, the stratum basale. The stratum basale is also called as stratum germinativum. Why it is called stratum germinativum? Because it is having some of the stem cells, and the stem cells are germinating or giving more cells. They are adding more and more cells from the base, because we understand the superficial cells are being lost. So you need to repair the epithelium from below. So this is the stratum germinativum, where you have the germ cells or the stem cells. That is why the name is stratum germinativum. And sometimes they are asking you about the stratum INI-PG also. If they say stratum INI-PG, then basically it is the layer number 4 and 5. That means the stratum spinosum and the stratum basale. So layer number 4 and layer number 5, if you add them together, then this will be the stratum INI-PG. Now let us come back to the various type of cells in the stratum basale. Number 1, we have talked about the stem cell. Number 2, it is the melanocyte. As we understand, melanocytes will be coming from neural crest cells. Otherwise, this is the skin epithelium, the skin epidermis. It will come from surface ectoderm. So all the cells here, except few, in the skin epithelium will come from surface ectoderm. So what are the few exceptions? One of that is the melanocyte. Melanocyte is coming from melanoblast, which is coming from neural crest cell, the 4th germ layer. And these melanocytes, they'll be forming melanin. As you notice, the cell is in the basal layer, but the processes are extending into the upper layers as well. That is into stratum spinosum and giving the melanin into the keratinocytes. So melanin can be found not only in the melanocyte, but also it is found in the upper layers, the keratinocytes. And that melanin is important to counter the ultraviolet radiations of the sunlight, preventing damage to the skin. And there is another cell in the basal layer, that is the Merkel cell. This is the Merkel cell, which is also found in the basal layer. It is actually one of the receptor for light touch sensation. Like I'm holding the pencil in my fingers, and that light touch sensation is being detected by the Merkel cell. It is in the basal layer of the skin epithelium and detects the light touch. You can see a nerve fiber also reaching it, carrying information from here. So 3 type of cells in the basal layer: stratum basale, that is the Merkel cell, the stem cell, and the melanocyte. Then you will notice there is another cell to be discussed, which is not in the basal layer. It is actually in the middle layer, that is stratum spinosum. This is the Langerhans cell, and Langerhans cell is not coming from surface ectoderm. It is coming from the bone marrow, that is mesodermal in origin. It is a migratory cell. It is antigen presenting cell. It is monocyte phagocyte series. So bone marrow at very early stage will give us the antigen presenting cells. They migrate, and one of such migratory cell is the Langerhans cell. It is the first line of defense, antigen presenting cell. It will pick up the antigen on the skin and carry it towards the lymph node. So they can be seen in the skin epidermis, in the middle layers, and also in the lymph node and other places in the body.